In this video titled Not So Minimal for a Minimally Invasive Surgery, we describe our technique of using a 26 gauge needle over a 41 gauge needle in performing the retinotomy and subsequent injection of recombinant tissue plasminogen activator for cases with submacular hemorrhage. We have no financial interest for this technique. Submacular hemorrhage is an accumulation of blood either between the neurosensory retina and the retinal pigment epithelium or between the retinal pigment epithelium and the Bruch's membrane. It poses a potential threat to vision if left untreated. It can arise either from a retinal or from a choroidal circulation. Now the question arises, so as why to intervene in such a cases? It's because it induces an irreversible retinal damage within 24 hours and loss of photoreceptors after 7 days, and it acts as a diffusion barrier for the flow of nutrients. Of the various treatment options available in the literature, the most preferred being pars plana vitrectomy with intravitreal gas injection plus an anti-VEGF injection and a subretinal injection of recombinant tissue plasminogen activator through a 41 gauge needle. The 41 gauge needle is housed over a 30 gauge needle for its easy insertion through a 23 gauge or a 25 gauge vitrectomy port. The disadvantage being its malleability, the resistance for the subretinal injection and its cost. Sharing our experience with 41 gauge needle through a 23 gauge port, this is a case of a vitreous hemorrhage with breakthrough bleed secondary to a choroidal neovascular membrane. Performing a routine 23 gauge pars plana vitrectomy for clearing the vitreous hemorrhage, we were able to visualize the subretinal hemorrhage. Here, we are trying to create a small retinotomy using a 41 gauge needle, and as we can see, the malleable nature of the 41 gauge needle is causing it to bend, and the transmitted forces which are generated at the tip of the needle causing the retinotomy to extend, which was not intended. A second attempt at a different site altogether caused an iatrogenic retinal break. In case of the 41 gauge needle, we inject the recombinant tissue plasminogen activator first, as the consensus is that it won't offer much resistance due to its small size and internal diameter. But on the contrary, it can cause an inadvertent large retinotomy due to its flexible nature. And also, the resistance offered for the subretinal injection is higher, causing efflux of the injected drug into the vitreous cavity, decreasing its availability in the subretinal space. So, we thought, is there any way to avoid such complications? We came up with an idea of using a more easily available, less malleable, larger but 26 gauge needle for performing a subretinal injection with a unique improvisation. Here is a 69-year male presented to us as a known case of polypoidal choroidal vasculopathy already treated with multiple anti-VEGF injections with best corrected visual acuity of counting finger close to face, showing a persisting submacular hemorrhage in right eye. After completing the vitrectomy, we have used a 26 gauge needle to make a retinotomy incision, and we injected an air bubble into the subretinal space first, thereby creating an even plane underneath the retina. The buoyancy of the subretinal air, by decreasing the resistance, it helps in the even spread of the recombinant tissue plasminogen activator, which is now injected subsequently. The air, it also tamponates the retinotomy, preventing the efflux of the injected drug. The SF6 gas is injected intravitreally, followed by intravitreal anti-VEGF at the end of surgery. 1 month post-op picture, it shows the hemorrhage to be cleared of the macula with improvement in visual acuity to 6/60, with regaining of a near normal foveal contour and resorption of the hemorrhage. The second case is a 62-year female with best corrected visual acuity of 6 by 60 in left eye. Clinical examination showed the presence of a vitreous hemorrhage and subretinal hemorrhage. Due to media haze, the color photo and OCT were not possible. Ultrasound B scan, it showed a subretinal hemorrhage. A 23 gauge pars plana vitrectomy along with chandelier illumination was performed and the vitreous hemorrhage was cleared. The PVD was induced and the subretinal hemorrhage was located mainly at the posterior pole below the inferior arcade. Then we performed the same technique of injecting the subretinal air bubble and the subsequent injection of recombinant tissue plasminogen activator underneath it. The SF6 gas was injected intravitreally followed by intravitreal anti-VEGF at the end of the surgery. 1 month post-op picture, it shows the hebe to be displaced inferiorly with relative flattening of the foveal contour. A detailed analysis of the aforementioned cases in our study proves the advantages of 26 gauge needle, which is cheaper, stable and more readily available. The retinotomy created is of the intended size and self-sealing, which does not require a laser. And the injection of air bubble provides more availability of the drug in the subretinal space, thus enhancing its activity and improving the postoperative outcome. Thanks for watching. Hope this not so minimal technique will help in achieving the maximum results.